to the beginning and start with my karakia. Whaia te tika, whaia te maramatanga, whaia te kotahitanga, he oranga mō tātou, tihe Māori ora. Welcome everybody to our talk today about hope and uncertainty in palliative care. When I looked at this definition, I thought, wow, there is so much in this definition. We're talking about something which is dynamic, so changing, a force which is changing and characterized by uncertain expectation of achieving a future good, which I think itself is interesting because it doesn't have to be a certain expectation. It can be uncertain. To the hoping person, it needs to be both realistic and also significant. As we go through the presentation, hopefully we'll think more about how we ourselves would define hope. So I'm going to move on to a psychological model of hope presented by Snyder in 1994. He talks about hope involving three aspects. So we have a need to be able to identify our goals, find pathways to achieve them, and also maintain motivation to pursue those goals. Snyder developed a framework of hope theory. And the interesting thing is when you look at these three aspects, people who anchor their thinking about the future to specific goals are more hopeful. And certainly in palliative care, I think we find people talk, for example, about, oh, I'd like to get to my daughter's graduation. I would like to get married. These are things that people often identify, so they have specific goals. And actually that, even if to us that might be unrealistic, those make people more hopeful. Those that are capable of pursuing those goals have to believe in their own capacity. And if they do believe in that, then they're more hopeful than others who don't. And those that can imagine or plan ways how they can achieve that goal step by step are also more hopeful. So in palliative care context, we have a lot of work has been done by Nikolajczak and Barrera. This has come from their 1998 paper, when they said, hope is not simply optimism or denial. I want to emphasize that hope is not simply optimism or denial, but a complex, evolving construct that can coexist with the awareness of dying. So they go on to talk about dimensions of hope, which I'd just like to reflect on briefly. So a personal dimension of hope, where hope comes from also a dynamic process that also combines our past experience, our present, but also how we see the future. It also can be situational, so it has to emphasize the situational experience. What situation are we in currently right now? For example, we might know that we've got a cancer and we have a shortened term to live. So our hope is defined within that situation. And also interpersonal, which I think is an interesting one for us, because hope has to be balanced and truth-telling, both between the patient that we're looking for, but also the family, and who cares for that person will also be another dimension of hope, the hope that they carry. So the personal, the situational, and the interpersonal dimensions of hope. Hope, if we look at other parts of the health sector, is seen as a marker for better outcomes. And some of the work that's been done in this space is really interesting. You'll see this particular piece of work includes Keith Petrie, who works at Auckland University. His study showed that when people draw their own heart after a myocardial infarction, the size of or heart attack, the size of the damage they draw predicts their return to work, their perceived recovery, and their functional status, better than the actual reality of how severe the heart attack was. So we find that hope can drive a better outcome, a better functional outcome. And they also went on to study people sometime later, so at 3 months, and they showed that the larger the drawn image, the image of damage from the heart attack, the more distress and negative beliefs people had, and the higher the PTSD at 3 months. So not only was hope related to their functional outcomes, it was also related to their psychological outcomes. So we can start to see the importance of hope for our patients. Hope, therefore, isn't just an emotion we have learned, it's also cognition. It lives in how people interpret the situation they're in. It wasn't the impact of the heart attack that affected these people, but the story that they created about their heart. So illness can't therefore just be biological. It's also how we interpret things and how we interpret things for ourselves. On the other side of the scale is hopelessness. And way back before in 400 BC, Thucydides was talking about hopelessness. He felt that those people who were hopeless were more likely to succumb to illness during the Athenian plague. So he notes that helplessness was the most terrible thing about the Athenian plague because it led those who became ill to succumb more easily. So there are a couple of scales which try to estimate how hopeful people are. And this is one of them that I found, the adult hope scale. I think it's interesting just to see a few of these aspects that are identified within the hope scale. So my past experiences have prepared me well for the future. Here we're thinking about that personal that we also had discussed earlier. There are lots of ways around my problem. So we can see the pathway issue coming in here. People can find another way to think about things. I energetically pursue my goals. So despite the situation we're in, we're still thinking about something that we would be able to do within it. So that's the adult hope scale. And another scale that's been introduced is the Hearth Hope Index, which is applied more in palliative care. So you'll notice some of these ones. I feel alone. I think those of us who work in this area definitely can feel the strength of people who have lots of people supporting them and around them. I can recall happy, joyful times. And I like this one. I'm able to give and receive caring, stroke love. I feel like whatever your physical situation, knowing that you're able to give and receive caring and love, I can imagine would provide a great sense of hope. And I think these ones, knowing these helps us also think about how our patients are feeling and seeing life. So I've got a poll question for you now, which is, which of the following is most likely to reduce a patient's hope? Discussing prognosis honestly, acknowledging uncertainty, exploring what the patient is hoping for, or poor symptom control. And this is based on the evidence to date of what we know. So you should be able to interact with the poll question, and then I'll give you a few minutes and then we'll look at those results. It's the first poll coming up now. I'm not allowed to vote, by the way. Hopefully we'll have some results coming in soon. Look at that. Most people said poor symptom control, which actually I was surprised at, but that is the evidence does show that if you have poor symptom control, it's very hard to be hopeful. So yeah, I had to put that one in. So I'm going to go on to talk about a case. And this case is and at the end of when I've talked through the case, I'm going to invite one of our nurses, Amy, who was involved with this case, to talk to us a bit about it. So Paul, and reflect on her management and working with this patient. Pauline's a 56-year-old Maori woman who works as an operations manager. She has 2 adult sons who live with her and her husband. She was diagnosed with an angiosarcoma of her left fibula in 2024, which had metastasized to her spine and lung. And that diagnosis came only a month after her father's death. When she was referred to palliative care, she'd received a couple of lines of chemotherapy and was on further treatment. She'd also had recent radiation to try and manage the bony pain she was getting. She was still working a day a week despite not being able to weight bear on her left leg, and she really wanted to focus on time with her family and also continuing treatments that gave her more time. So the family were positive, and yet they were realistic also about her condition. She was told her prognosis was about 12 to 18 months, and that was already a year into it when we met her. She remained optimistic, and importantly, aside from mobility issues, her symptoms were well managed with pain medication regimen. Pauline felt that her family were her greatest support, and her husband were very emphasized always the importance of being together as a family unit. They'd also purchased a puppy since she was diagnosed to give her more comfort. She practiced mindfulness daily and enjoyed massage and aromatherapy. Her left leg gave her increasing problems with the mobility and swelling, and she decided to undergo a left leg amputation. While we were looking after her, and recently she moved to a newly built house and wanted to focus on new goals of getting around and learning to live without the leg. So she also had OT support to help her with these functional tasks. So that's a summary of the case. However, I really want to invite Amy to join us to talk to us more about how she interacted with the patient and what she learned from her. Hello, Amy.
Hello,
Thank you for
kia ora.
joining us. Kia
Yeah.
ora.
First, I just want to say that it's an honor to work with Pauline. She's courageous. And in my nursing role, working with her, I acknowledged the first time I met her, her anxiety and her worries about her future, and simply suggested a non-pharmacological nursing intervention, which was mindfulness and some simple aromatherapy, which she was open to. And so she simply just closed down her eyes and participated in a 10-minute mindfulness session with me. I kept my eyes open and I watched Pauline, and I witnessed tears running down her cheeks, and I was had mixed feelings if I was actually helping her or if I was hurting the situation. So in myself, I was feeling a bit anxious. But then after the practice was finished, Pauline opened her eyes and shared how she felt a sense of peace. Um, the practice remains a really grounding technique for her, and she shares that it enables her to focus on the moment, and she's able to cultivate gratitude and for the good days, even amidst all the challenges she's faced. Initially, she shared that she really hoped for a cure. However, as her cancer progressed, she knew this wasn't a possibility, and she did have the leg amputated just recently, and her hope has shifted. Um, she continues to redefine her expectations and concentrates on living in the present moment, and is just after about a month out of having her leg amputated, she's planned a trip to Rarotonga. So she's a real inspiration.
Wow. Yeah, and that's really interesting that she was able to shift and change that hope in the different situations she found herself in.
Mm, absolutely.
What do you think particularly helped her do that? Because that sounds quite a challenge and quite a hard thing to do.
I think she gets a lot of joy from her family and being able to just sit back in the present moment and feel the joy that she receives from her two loving boys, and knowing that her life is going to be different, but just spending each day with them and making the best of each day that she has, and
Great.
stop that racing brain.
Yeah, and I guess the mindfulness really helped with that as well.
Yeah, it really has. It really has.
Great. Thanks so much, Amy. And
Yeah,
we'll see Amy again at the end of the presentation when we'll invite her to join us for the panel.
thank you.
Thanks, Amy.
Thank you.
So hope, as we can see in that case, shifts. It doesn't disappear. It can be changed and reshaped despite a diagnosis or prognosis which is very short, we can still live meaningfully or be comfortable or still matter. So it's possible, or it's hypothesized that maybe where cure is not possible, then the story you make may matter even more. Because hope lives inside that story that we create for ourselves. We can hold the same story and be hopeful. If the story we make for ourselves is adapting, then we can be hopeful. If the story is I'm broken, then it's very difficult to maintain any hope. So the next poll question that I've got for you is I'm going to read the statement, and then it's how should this be understood? I know I'm dying, but I still hope I'll get better. How should that be understood? Is the patient in denial? Does the patient not understand their prognosis? Can hope and awareness of dying coexist, or has the clinician probably communicated poorly? So I've got those up there for you, and we'll give you a few minutes to answer that. I think that. Okay, so majority of people say hope and awareness of dying can coexist, which is fantastic. I feel that although we might know that, sometimes I think that we don't necessarily put that in practice in our everyday work, because sometimes we do feel that maybe we do talk about patients being in denial. We do wonder and try to repeat the communication to see if they can understand better what's going on for them. So it's interesting that despite the fact we know that hope and awareness of dying can coexist, we still maybe use like different language or language that might not be that helpful. So I'm going to move to another case, and I'm going to call this gentleman Solomon, 60-year-old man who was diagnosed with locally advanced and metastatic rectal adenocarcinoma at the end of 25. The tumor was invading his prostate and there were suspicious pulmonary lesions. And Solomon lived on his own. His wife had died of cancer only a few days before. She'd been a lot younger than him and they had had a lovely relationship. And this loss was still very raw for him. He was very adamant from the beginning about treatments he would or would not accept for his condition and had his own way of determining what he wanted to do. In recent weeks, scanning has shown progression of his disease, and Solomon had discussed next steps with us. He had wanted to discuss the option of assisted dying. If I can't go back to being who I was and doing what I used to do, then I might take that approach, you would say. At the same time, he maintained hope that the chemotherapy was working and would actually provide a cure for him. So he was somebody who was able to hold two beliefs at the same time. I'm going to ask, I'm hoping Louise is there to come and talk to us about her experience with this patient. Welcome, Louise.
Thanks for having me.
This is a patient that we looked after together, but I would really be keen to hear Louise's impressions about how he managed that illness and his own sense of hope. And
Yep. Solomon has been a very interesting gentleman to get to know and understand. He really shows an incredible resilience, I think, from, just his history, things that have happened before us even meeting him. And then a man, living on his own, facing a terminal illness, and sort of, as Celia's mentioned, walking these two journeys at the same time, very, very hopeful and insistent on having treatment and very much exploring every avenue possible to understand what options are available to him, whether that's through the public system, the private system, even going as far as looking at what's available to him in Australia. At times, we did wonder if he understood sort of the reality of his situation. And I think there was just this desire to hold himself as a person and the function that he had. And we can sort of see that now in recent times that we've seen him as, things have progressed and changed. And as sort of that sentence has said, if I can't go back to who I was, looking at these other options. So while there's been this constant drive to, want to continue active treatment and do as much as possible, he's also made sure to have other plans of, making sure his funeral arrangements are taken care of in quite detailed, electing his power of attorney, having a will done, all of that documentation. So there is this complete insight of what's happening for him, and a complete understanding that he will die at some point in this journey, but still very hopeful that things could improve, that he could feel better. And I think he's just been really grateful for the support and just even the responsiveness to from us to help him. I think has even given him hope that people are here and want to help him. And I think he's really been appreciative of that throughout the time we've known him.
Yeah, and reflecting on his journey in the light of hope, I feel like actually he did change what he was thinking and wanting to do, because he decided he would buy himself a new sofa and a new rug. And I think that was when he was really realizing that things maybe weren't going to go how he hoped, even though he wanted to still verbalize that. And one of the things he had always wanted to do is get a certain large motorbike, and still drive around on that. And I think that was hard because he had that goal, but he realized that he wouldn't be able to achieve that.
Yeah.
Thanks, Louise. That's really helpful. Thanks for joining us, and we'll meet you again in the panel at the end.
Thank you. Thanks.
So, is there such a thing as unrealistic hope? I think there's three issues that we're talking about here. One is about trust. If we confront or correct this hope that somebody might have, can we damage trust and increase their distress? Certainly, evidence show us that patients can hold simultaneous awareness and also hope. And the misunderstanding, I guess, is that hope often reflects a way of coping, of making meaning or relational needs, and isn't misunderstanding on its own. And that's certainly, I think, what we found in Solomon's case. So why does this occur? There's a feeling that there's probably a bit of a need for control when there's uncertainty, for protection from the reality of what's happening, and for maintaining your own identity and roles, as well as kind of a cultural and spiritual beliefs. So it matters because it's not just about misunderstanding. If you're unrealistic, what we might call unrealistic hope, it may lead to overtreatment, or we're worried that it results in a lack of preparation. And if it's challenged, it can definitely lead to a lack of trust. It certainly reminds me of a young woman that we had who we looked after, Amy and I looked after, who had a sarcoma. And she did not want to talk about her death or dying, and she only wanted to talk about treatment and cure with us. However, she was happy enough to let us in to help her and support her with symptom management issues. At times it felt that we were concerned that she might not have prepared herself. However, as time went by, it became really clear that she'd had conversations, but not with us. She'd made preparations, but not told us. And she wanted to keep us in that space of managing symptom management. So what approach do we take when people are in this situation or in this space? There's a recommendation that we acknowledge the hope that they have. we can align ourselves with that hope. We can say, I wish that for you. I really wish that you will be able to live for another few years. I really hope that you do get to your daughter's graduation next year. We can also expand that hope. Say, okay, so you have this is one of your hopes, but is there something else that you would like, another hope that you have that may be something that is a shorter time frame? So we can ask them to think a bit more about their hope and goals and see if we can change or expand, so add to the ones that they have. And this one, I think I found as I was preparing for this talk, a plan for a what if. We often talk about hoping for the best and preparing for the worst. I found that some articles challenged this position, saying that actually some people are the sort of people that plan for the worst, and others their preference is not to do that. They want to hope for the best without the planning. So it may be that we have to be a bit more flexible around that approach to people. We can also unintentionally, as health professionals, damage hope. We can add to that story that people are making for themselves, whether we realize it or not. I'm sure that we know a lot of patients who've come back from the hospital saying, oh, I was told there's nothing else we can do. Is that a helpful thing that we say? We often say things which probably do take away agency and disempower people. It may be instead we're shifting the focus of care. You may not be able to do more than you can do now. So how we talk can also shape that story that the patient makes for themselves. So my third and last poll question, what effect does honest communication about prognosis typically have on patient hope? It usually destroys hope, increases depression, allows hope to shift to realistic goals, or it leads patients to refuse treatments. I think I've been making these too easy for you. What are we doing? Yep, it allows hope to shift to realistic goals. So the third case we're going to talk about is Julie, who was diagnosed with metastatic breast cancer in 2021 after a year of noticing an enlarging breast mass. She initially underwent a partial mastectomy and chemotherapy. In 2024, she was found to have lung metastases, and the oncologist strongly recommended further chemotherapy, which she declined as she felt well. In 2025, she had an increase in her lung mets and was frightened by the fact she had some blood in her sputum. However, she again declined treatment. She remained concerned about worsening cough and chest symptoms, and she did want regular imaging and follow-up, even though that she didn't want treatment. She preferred taking natural remedies and had a very strong faith in her God, praying every day for strength and healing, which gives her hope. She prides herself on being fit and strong, attending our regular exercise class. She believed that these things will help her live as long as possible, and her husband shared that hope with her. So I'm going to invite Jen to join us this morning. Jen's one of our amazing physios who's still involved with Julie, and also she's also going to talk a bit about Charlie's impression, who is one of the nurses that worked with Julie as well, who couldn't be here with us today. Welcome, Jen.
Thank you. Good morning, everyone. I'm just going to read a few words from Charlie's nursing perspective. So Charlie said that I guess the struggle in this situation is that although she has hope, she still asks every time I see her why her cough is so bad and what can be done. Again, we come back to how treatment can support her and improve the symptom for her, but she continues to decline any intervention. I admire her hope and, of course, support her in her decision making. From my point of view, I make sure she knows all the facts to support her decision. And whenever she has a scan, we spend some time talking through it so she understands what it means and what the oncology advice is. I think in palliative care, and all areas of medicine. There will be decisions made by patients that are based on their feelings of hope that we may not agree with. I don't want to squash that hope for them, as I think this is what helps people fight their disease. But I do see our role as ensuring they know all the facts and options, and then they know that they can change their minds, whilst also acknowledging that treatment may not continue to be feasible or inappropriate because she becomes too unwell or her disease is too advanced by the time they agree to treatment.
Thanks,
So
Jen.
just a few words about Julie and her, what I see when she's in the exercise class. So Julie is at the exercise class. I would describe her as full of life with a compelling authenticity, which is a joy to be around and makes her very relatable. She's got a raw combination. I've been really watching and fascinated and learning myself by her attitude, but I'm reflecting now on this presentation today because she's living a life where she is facing fear, and it's palpable, it's there. We can all feel it in the group and we all feel it together. Everyone's fear, actually, I would say. But through that, there's hope. And her hope displays itself as a joy. She's lively, she's committed and dedicated, and gives it her best. She's determined to live. She has strong goals. She's got fear that she allows it to be displayed, and people find that a relief because it's there, and she doesn't deny it, but she lives with it. And she's, I think, I don't know whether I've said that she gets described as a firecracker. I've heard it more than once in the group. She's determined to live. She has a strong sense of faith. She has a faith across a wide range. She has faith in God. She has faith in herself. And she has a faith in resources that she can access. So I don't know. I think that's it for Julie. It does feel a bit emotional and hopeful talking about her because she does have an effect. And her pain, when her emotions rise, as they do in the group during exercise, and it's like that's a tool. Exercise seems to be a tool for her to let out her feelings, and other people appreciate that because it's out for us all to look at and exercise through it and work through it.
Great, Jen, thank you. It just illustrates clearly some of those things about agency that she has really strongly, and also that she finds it helpful to talk about those fears in that group. Sounds fascinating. She's certainly an incredible woman, eh? And if you think about it, she's decided she didn't want any treatment, and she's really living life, isn't she? Every day you always see her when she comes into hospice with a big smile on her face. So yeah, brave woman. Thank you very much for highlighting some of her story for us.
Thank you.
We'll see Jen as well at the end. So hope, as we've illustrated with some of these patients, is dynamic in palliative care. It changes over time as our illness progresses. It includes goals and relationships, and it's about meaning and comfort, not just cure. It also can coexist with reality. So what can we do to enhance hope? We've seen all of the benefits that it can give. I guess one of the things that we can do is support our patients to reframe the hope they have and consider achievable goals, which may be aligned with or also in concurrence with other goals that they might have. We can name the uncertainty without challenging it. I worry that this might happen. I hope the same, that you will get cured from this disease. I wish it would go away. Sometimes I say I wish for a magic wand to take it away for you. We can also expand the types of hope. What are you hoping for? in the hopes that you have for your family and the hopes that you have for comfort. Some other strategies that we can use is to protect people's agency, offer more meaningful choices, but also support the control that people have in their own destiny. There also family connection has been found really important in a space in hope. And we can see there where we talked about Julie, her husband's a really important presence in her life and supports all her hope. And the avoidance, therefore, as well, of abandonment. And we can also ensure people know that we are not going to be abandoning them. Symptom control, as we also heard, directly supports hope. And if we do get a rapid response, obviously that helps us build trust. So in summary, hope persists throughout serious illness and dying, although it does change form. It's often expressed through different relationships, through meaning and through presence. It's something that we should protect, encourage, and at times we hope we can gently reshape. So that's the end of my presentation. We're going to move to opening up the panel to answer any questions for us. So I'd like to invite the panel to come and join me. I'm just going to stop sharing my screen. Hello, everyone. Thank you for joining me today. I will just introduce you, because Catherine, you haven't been on the webinar so far. So welcome to Catherine Marks, who's one of our therapists in the team. Jen is one of our physios, and Amy and Louise work with us as specialist nurses in the team. So I'm just going to see if I can see more of the questions. Question and answers. Okay, great. So my first question, perhaps I can direct to you, Catherine, and that is, how do you as a team manage your own hope? And how do you prevent yourselves from going into despair when you manage these situations so frequently?
Thank you for this, Celia. It was really lovely to spend some time with this elusive concept that is hope, and that is such a fragile and, like all of you said, such a thing that needs to be reshaped time and time again. Really beautiful to spend the morning with this. And Atamari and Morena to everyone out there in the virtual space. How do we do it as a team, or how do I do it? I think one of the core things in regards to maintaining a sense of hope in the palliative space is beginning with my own mortality and being aware that I'm not preparing for the worst. Patients are actually not preparing for the worst. We're preparing for an end of life that is awaiting all of us. And it is, how do we get to the end of that journey? How can we support people on their journey, that I think makes a difference. And for myself as well, to not shy away from my own mortality, to face it, to face the feelings that come with that. And like you just said, Celia, how to not be dragged down into despair. Despair is there at times, and that's okay. I think it's creating a space where all these emotions can coexist, where all of that gets a place. That realistic hope that you talked about, Celia. And I think as much as we hope for the people that we meet in our service to have hope that feels more relational, more presence-based, more what can happen today, how can I attend to my pain or the symptoms that I experience today? What is something that gives me meaning today? That can also apply to myself. What is it that can give me a sense of joy, of beauty, of hope in the everyday rather than the big things? And I think that is something that is really, vital. It's a bit like I have dreams of, I hope I can do more overseas trips and do all of that, but it is so future based. I can't, I have no agency about that. I could die today with the brain aneurysm. It's the reality that we actually can't plan that far. So in that sense, hope becomes very distilled, very distilled and very yeah, I can't think of the word now, but it becomes such a potent thing in the everyday, the meaning that is in the little things. And I think that's something that can really help.
Yeah, it brings me to mind about how when patients say, "Oh, I want to get to Christmas," and
Yeah.
sometimes we would say, "Well, you could have Christmas next week,
Yeah.
Let's organize Christmas.
Yeah.
And if you get to Christmas as well, then you get to." That's a way we sometimes try to bring that goal
Yeah.
kind of nearer, I guess, for people. Okay, thanks. I might turn to you, Amy, and ask you because I can see some other questions coming up. But how do you explore people's feelings of hope? So what language do you find helpful when talking to them about hope?
Gentle, gentle. I explore people's hope, I guess, by checking in to see what makes life worth living for them, which hopefully is a reminder of why they want to live. And I guess another thing that I look at is what I need to know about them in order to provide the best care, and so I can move forward with them as a walking alongside this journey for them, and as hope changes for them, um, and assuring them that we are there for them along this journey, and stating that what can we do to help you get there, with these goals and hope that they hold on to.
Great. Thanks, Amy. That's really helpful. The other thing that's come up is how often do we come across people who hold those dual thoughts of being able to hoping for something, hoping for a cure, but also talking about what they'll do if it doesn't work. Louise, maybe you could comment on, do you think that happens often in your work, or is it just a rare event?
Before probably coming into palliative care and sort of with hospice, I would have thought that didn't happen often, but I've actually noticed it's more common than not. The concept of hospice and palliative care being involved for people is quite a scary thought, and I think it holds a certain idea among a lot of people, and so I think when we're able to step in and help them understand that while an illness may be terminal, whether that is a cancer or a chronic condition, our aim of helping your quality of life, your symptoms, keeping what's important to you, helping you be able to do those things. It may look a little bit different than it used to, but we can try, and that we can care for you for a long time. But we have to anticipate that things may change, and I think people, for various reasons, are much more perceptive to that idea. I think it's the idea of, a few things you've mentioned through the webinar. It's having some of that control in making their decisions, whether that's, in life and in death, been a burden. And that looks different for everyone. But I think some people understand what a huge undertaking, end of life care and those big decisions can be, and, don't want to have to put that on their family or friends to manage that as well. So while you can be hopeful and, continue having treatment or not and just living your best life that you can also plan for these things, and one doesn't make the other one happen faster. I think that's the big
Yes.
idea, is talking about death brings it on.
Mm.
And it very much doesn't. It gives you strength to know that you've made those decisions and things can happen the way you
Yeah.
want them to. Yeah.
that's a lovely reflection. I love
Mm.
that comment. It doesn't bring it on faster because you do get the impression that that's, yeah. And I hear what you were saying, Amy, about the gentle, because I think some about that giving people control is asking permission to talk. We often talk about asking permission to talk about things. Is it okay if we talk about, if things didn't turn out like that? It's kind of one of those more gentle approaches, which I agree with you, Amy. It's really important for us to make. Thinking about function, Jen, how do you feel? Do small changes in people's function can give them a lot of hope? It seems to me that it could. I just would love to hear from you about that.
Yes, well, I think in practice we see that movement really does matter to people on whatever scale they can manage. It's really surprising. It can generate laughter, all those things that comes with hope, um, joy, just from even any movement. So when function improves and it's realistic, it might even be rolling in a bed, or it might be a caregiver's ability to do some range of movement exercises that can help with comfort. People do appreciate that in the moment because that's where hope can exist right there in that moment.
Yeah, so that's bringing back to what Catherine was saying is what is it today that can give us hope? Yeah. The last question I see someone has asked about when how family members are involved in supporting people or maybe even encouraging a hope. I don't know if Catherine, if that's something you could either if family members are on the same page or maybe even have differing approaches to this.
I think it's a complexity that we see all the time, isn't it? That the patient has one idea and then family members have differing ideas depending on how they feel about the notion of death, what the circumstances of the person's life is, how old is the person, what other social things are impacted there. I think one of the core things there is acknowledging the emotions that are underneath that and the fears or concerns that are underlying that, and to really attend to that and be curious about why are the hopes different? What are you hoping for? And I think often giving room to the grief that is underneath that I know that you're hoping for another few years and that these magic remedies are going to help. And yet at the end of the day is still going to be death that's waiting. And like Amy said, gentle, gentle, not barge in there and name it just like that, but to slowly, gently, it's almost like teasing apart the stories and where those perspectives come from, and to have a space where that grief can be heard. And to come back to relationality and to the moment as much as you can. And sometimes realistically this is not going to happen. Sometimes it's just going to stay complicated. It's not always going to be a magic
Mm.
one magic or a series of conversations is going to magically make that go away. It is just messy. It is complicated.
It reminds me of a family where I'm wondering sometimes if a couple maybe try to talk about hope constantly between each other, but underneath they would prefer to have a discussion which is deeper and more about the problem that's coming, but they encourage each other's hope in a way of deflecting from discussing bigger issues. I don't know if that's something that you see a bit.
I see that sometimes, yeah. And I think, and I just saw a question pop up about what do you do with unrealistic hope? I think it is the notion of you stay with that experience. You don't try to block it or to make it go away. You accept it. You gently stay with that. And I think it can be as simple as talking about the general trajectory of life that we all have. Most of us are born into wellness. At some point we get sick, and then we fluctuate between the two. And at some point in our life, we will be dying, and death will welcome us into whatever lies beyond. And to just talk about it generally, look, we don't know what's going to happen. Let's just prepare for what will be there for all of us at the end of life, and to open conversations from there, to not talk about time frames, to hover that to the side to talk more about the general trajectory of life and how can we keep on living until that happens, no matter how long or short that may be.
Thank you, Catherine. That's really lovely reflections. And I think probably, although we'll be finishing a bit early, I think it will be, no one will mind that. It's still the beginning of the working day. Thank you guys all for your reflections. I'm going to just repeat our karakia, and then we'll be putting up the slide which shows you our contact numbers, as well as asking you to fill out the evaluation if that's possible for us. So thank you everyone for joining us today, and thank you particularly to our panelists for coming. I know poor Louise has been juggling family, as a young family as well this morning, so a particular thank you to her. Whaia te tika, whaia te maramatanga, whaia te kotahitanga, e oranga mō tātou, tihei mōri ora. Thank you, everyone. Have a good day.